Welcome and thank you for joining today's webinar. This is the first of 3 sessions in this webinar series on child protection and health integration during major disease outbreaks, produced by the BHA-funded READY initiative. We are happy to provide live interpretation into French and Arabic for today's webinar. If you're interested in listening to the session in one of these languages, please click the globe icon that says interpretation at the bottom of your screen and select your desired language. During this webinar, we encourage you to ask questions using the Q&A function. And access to today's recording will be available on the READY website. It is now my pleasure to hand it over to Sarah Collis-Kerr, the lead technical advisor for the READY initiative. Sarah. Oh, Sarah, unmute, please.
It's a good start, isn't it? Welcome, everyone. Thanks, Vasika. And thanks again for taking the time out of your very busy schedules to participate in READY's first webinar in this 3-part series. And we're going to be focusing on understanding the centrality of children and their protection in infectious disease outbreaks. Very quickly, I wanted to tell you a little bit about READY. The READY initiative has been in existence since 2018 now, and it's funded by the Bureau for Humanitarian Assistance. We're a consortium of partners with Save the Children as the lead. We also have Johns Hopkins University Centre for Humanitarian Health, Centre for Communication Programmes, UK Med, a health NGO, and the Humanitarian Leadership Academy. Our goal is for NGOs to have the tools, knowledge and skills to support crisis-affected communities and local authorities to effectively respond to major epidemics and pandemics in humanitarian settings. To do this, we work on a global level and we focus on identifying gaps and augmenting what already exists to strengthen NGO capacity in order to respond to major disease outbreaks through integrated and community-centered approaches. So what exactly does that look like? Well, this goal translates a lot of the time to webinars, policy papers, online courses and live trainings, digital outbreak simulations, mentorship, operational readiness trainings for outbreak response for both national and regional NGOs, multi-sectoral tools and guidelines, strategies, trainings, and the development of approaches to center communities in outbreak response. You can access more about the READY initiative on our website, which should now be in the chat. So now you know a little bit about READY, let us focus on the very important topic of this webinar, which is understanding the centrality of children and their protection in infectious disease outbreaks. I think we'll all agree that never has this topic been more important after seeing the recent Ebola outbreaks in Uganda and DRC, and an unprecedented number of cholera outbreaks worldwide, and not to mention the COVID-19 pandemic. We know that typically national and global efforts to prevent, respond to, and recover from outbreaks are led by the health sector, even when interventions for outbreaks are multi-sectoral in nature. There's clearly a growing and urgent need for timely child protection and health integration. And in order to achieve this, we need effective collaboration between the two sectors, child protection and health. And without this collaboration, we cannot ensure the needs of children and their families are prioritised during outbreak response. So to untangle this topic, I'm joined by some excellent presenters and panelists today to help us. If I could ask all of the panelists and presenters just to put their cameras on momentarily. So first we have Nidhi Kapoor, who is a child protection specialist and independent consultant working with READY. Nidhi is a protection, gender and inclusion specialist with 15 years of field-based experience and is currently supporting many activities within our READY initiative to improve collaboration between the health and child protection sector. Jean Sayanda is the Humanitarian Child Protection Advisor for the Global Centre Humanitarian Technical Team within Save the Children. Jean is currently the Child Protection Lead for the READY initiative and is overseeing the Child Protection US-funded portfolio for East and Southern Africa and some other countries within Asia and the Middle East. Violet Brungi is our guest speaker today for the case study. She's Head of Health and Nutrition for Save the Children Uganda Country Office. Violet has more than 15 years programming and management experience in health and nutrition, social behaviour change and communication, training, advocacy, WASH and community health projects, particularly for vulnerable groups in both humanitarian and development settings. We also have another case study from Dr. Alex Mutanganai, team leader of Save the Children Kinshasa Country Office in DRC. Dr. Alex is also the acting health and nutrition technical advisor, and he has served as clinical lead and health advisor with various international NGOs in Chad, Haiti, Guinea, and now DRC, responding to numerous humanitarian crises and infectious disease outbreaks. We also have Dr. Aisha Kadir, senior humanitarian health advisor for Save the Children. Aisha is a pediatrician, public health researcher who's focused on understanding and meeting the needs of children and families in deprivation and crisis settings. So, what will our webinar be about today? So just to give you an overview, first we'll explore why children are more vulnerable during outbreaks, and also what are the benefits of cross-sectoral collaboration. We will briefly visit the global laws and minimum standards underpinning child protection, and then we will hear from Violet Brungi and Dr. Alex about their work in Uganda and DRC, followed by an explanation of our 5 critical actions for child protection and health integration. After the presentation, there will be time for question and answers, and what I'm sure will be a very, very interesting discussion surrounding these topics. So, without further ado, I hand over to my ready colleague Nidhi to present. Nidhi, over to you.
Thank you, Sarah, and welcome to everyone. So why are children more vulnerable during outbreaks? I think we can summarize this by looking at both the direct and indirect impacts of outbreak to which children are both more vulnerable. So some of the examples of direct impacts include unique exposure pathways compared to adults. So children can be exposed to infection both in utero, during childbirth, even through breast milk, depending on the infectious disease. Children might have lower immune defenses. They might already have higher malnutrition, which can leave them more susceptible to certain diseases, for example, like cholera. We might have delayed treatment for children. So an example would be, we know that the Ebola symptoms mimic the early symptoms of malaria, and that may confuse practitioners and to delay treatment. Delayed treatment might also be because children are less able to communicate their symptoms depending on their age and developmental capacity. Children might be excluded from certain vaccinations because of their age or because of availability for vaccination for children under a certain age range. And children may be a bit less able to adhere to any recommended infection prevention and control measures. On the other hand, children are also more likely to be impacted indirectly by the outbreak itself. So that might be, in reality, things like family separation due to border closures. They might be in isolation, quarantine treatment themselves, or their caregivers might be, leading to family separation. They might have suffered the death of a loved one without the ability to mourn in customary ways during an outbreak, leading to enhanced, perhaps mental distress. Education is disrupted, which might also interrupt access to nutritious school meals that they might have been having before the outbreak. Because of increased stressors, they may be exposed to more violence in the home. Their routine immunizations may be suspended, and they might have lost support for any chronic illness or disability they may have had before the outbreak. And of course, we know that outbreaks can affect also social interaction, so they might have less access to their peers and to other support networks that they may have had as protective factors prior to the outbreak. So what's our primary objective as our respective sectors during outbreaks? And this is quite simplified what I'm presenting here, but it gets at the core of what our respective sectors are trying to achieve during outbreak management. At the broadest level, child protection actors look at harm to children. So this might be harm that's intentional or unintentional. It may be physical or psychological. And this includes harm caused by the disease itself, as well as by those indirect impacts of an outbreak. They do this by looking at the whole socio-ecology of the child, from the child itself to their family, their community, and even to the societal level. And we do this by identifying new and existing risk and protective factors in their environment. Whereas at the beginning of an outbreak, needs are high and health actors may have limited capacity to meet all the needs that may be there in any given context. The immediate priority is to actually prevent excess deaths and illness. And this is done primarily by introducing infection prevention and control measures, such as movement restrictions, school closures, hygiene and sanitation practices, bolstered by increased screening and possibly vaccination if it's available. Yet, despite this apparent disparity, there are ways for us to work together to benefit both children and to enhance the outcomes in both sectors. Just being told that there might be a technical problem. Are you able to hear me now?
We're able to hear you, yes.
Okay, great, thank you. Thanks, Oscar. So why should we work together as sectors? What are the benefits of child protection and health integration in outbreaks? So at this juncture, I'd like to welcome the audience to participate in this short activity. I'd like to give everyone 1 minute to think of an answer to this question about why should we work together, and to type their response in the chat box, but please don't press send yet. We'll give everyone a chance to type in their responses. And after about a minute, I'll say for us to press send all together at the same time. So please go ahead and write in your responses into the chat box. The question is, why should we work together in outbreaks? What are some of the potential benefits of protection and health integration in outbreaks? So go ahead and type in your responses. I'll just give everyone about a minute to respond, and we'll press send at the same time. So hold off pressing send for a moment if you can. All right, I hope everyone's ready now. Just give you another 10 seconds or so. All right, let me say 3, 2, 1, and we all press send now. Go ahead, please. There we go. Lots of responses coming up. And some really good ones. So you can take a minute to scroll through what our audience members have shared today. Virginie, could you please share the next slide? Thank you so much. All right, thanks to everyone for sharing your ideas. I see some are still coming in now. I'll take a moment to scroll through those. And as we do that, let me try to summarize some of the key reasons why integration makes sense during outbreaks. So here I have 9 reasons why, and I'm going to scroll through the chat to see if there's other reasons that the audience members may have shared, and let me see if I've captured everything here. So the first one is that we can jointly mitigate harm. Together, both sectors are uniquely placed to identify and implement mitigation measures to reduce potential harm experienced by children and their caregivers as an indirect impact of outbreak containment and control measures. The second reason to work together is that we can adapt service provision so that it better addresses the needs of children. So for example, health actors are trained in effective communication with children. They may have greater success in testing, treatment, and immunization of children. Child protection actors who are trained in necessary infection prevention and control measures can continue operating safely during outbreaks. Those are just 2 examples. The third reason why it makes sense to work together is that we can work together with colleagues specializing in mental health and psychosocial support, which cuts across both sectors. And we can do this to identify and address more holistically the immediate and long-term needs of children and their caregivers during outbreaks. The fourth reason is that we can jointly roll out coordinated awareness campaigns. So this might be part of our risk communication and community engagement strategies. Some people call it community sensitization, awareness raising. These different types of platforms can be used to have coherent, accessible, and inclusive messaging that targets children and their caregivers in a child-centered way. The fifth reason is that more children and their caregivers can be reached with quality services. Child protection actors who are trained in early detection of disease and preventive measures can recognize and refer cases of suspected they can refer cases of symptomatic children and caregivers. Health actors who are trained in child safeguarding and child protection are more likely to safely identify and appropriately refer cases of suspected abuse. The sixth reason is that child protection actors may be suspended or have restricted access to communities and health facilities, and the provision of child protection services can continue in some form if they're able to work together with health counterparts. The seventh reason is that we can jointly develop and disseminate shared standard operating procedures. So this might look like common information sharing or data protection protocols in regard to the safe identification, documentation, and timely referral of children in need of further case management support. The eighth reason is that we can standardize the disaggregation of data collection, analysis, and reporting at a minimum by age, gender, and disability. And that can in turn enable a more tailored response strategy. And finally, the ninth reason is that we can collectively mobilize resources and conduct joint advocacy to donors, which can lead to greater financing for integrated interventions. So I hope I captured the ideas of the audience. I'll have a scroll through and see if there's anything new that's come out. In the meantime, I'll pass to my colleague, Jean, who's the child protection lead for READY. Jean will share more about global norms and sector-specific standards related to the centrality of protection. Thanks.
Good afternoon, everyone, and thank you for being here. So firstly, I'll start by asking what is protection? And I know many of us are in that field or have interacted with your protection colleagues. And protection is simply promotion and protection of human rights. And it's in everything that we do, including response, prevention, mitigation, and preparatory work for outbreaks. What are the global efforts and commitments made by the humanitarian community, including the Interagency Standing Committee, the Child Protection Alliance in Humanitarian Action, the Global Protection Cluster, the Global Health Cluster, to name a few of which many organizations present in this webinar are a member of. They all have agreed that protection remains the core of all humanitarian action and are represented in the commitments within the centrality of protection, which according to the Interagency Standing Committee definition, centrality of protection states that protection is the purpose and intended outcome of humanitarian work. Underline purpose and intended outcome. To hit home with the theme of outbreaks, relevant to this webinar is the Standard 24 of the Child Protection Minimum Standards, which can be found on the Alliance website, which states that supporting children's health increases children's protective factors, while supporting children's protection can and should improve children's physical health and well-being. Lastly, protection mainstreaming, also a global commitment, I know many of you have heard that term, seeks to ensure that core humanitarian rights and principles are ingrained into all humanitarian action. There is a lot to be said on this and in the next round of webinars, but I would like to now cordially pass the baton to my colleague, Violet Birungi, Head of Health and Nutrition for Uganda, Country Office, Save the Children, who will present to us a case study with the most recent outbreak in Uganda. Over to you, Birungi.
Thank you so much, Jean. Good morning, good afternoon, everyone on the call. I just want to give a background about Ebola virus and then our experience to what we are having. In Uganda, on the 20th of September 2022, the Ministry of Health declared an outbreak of Sudan Ebola virus after a case managed at Mubende was actually identified, and therefore at Mubende Regional Referral after tests from Uganda Virus Research Institute. Up to date, We have 55 cases of patients or cases that passed on, that's the case fatality ratio, out of 142 cases that were confirmed, and then 87 recoveries. So according to Uganda, after the 42-day wait, the Ministry of Health declared Uganda Ebola-free on the 10th of January, 2023. But as Save the Children were part of the Ebola response in these key districts, the 9 districts that were all having Ebola, and this is what we had. So why is the integration needed? We realized when we went to the districts where there are hotspots, Mubende, Kasanda, that in addition to a high fatality rate, children were heavily impacted by the outbreak. We saw that schools were, of course, closed. National exams were actually missed by some of the children due to Ebola. There was family separation and accompanied children, those going to the Ebola treatment unit. Even when the adults or the parents were tested positive, they were separated, of course, and there was nothing considered for the children to stay with. And this led to child-headed households for some long time, depending on each case management. We saw death of some caregivers or parents of these children, and this increased child neglect and also violence against the children. There was a lot of stigmatization of Ebola survivors or family members, even up to now. And then this has also had a heavy burden on public health measures. For example, we saw a lot of households being burnt down, and also household items. This is because they wanted to control the infection. And by policy, households where we had infected positive cases, these had to be burnt and totally put out so that we avoid the further spread of this item of the Ebola disease. So what are we doing currently? We obtained funding from private donors from Save the Children, but specific funding for child protection activities came from UNICEF here in Uganda. And the key actions that we had, one was to put up standard operating procedures and referral pathways for identification of vulnerable children, especially those who are affected by the Ebola one. We continue to have to identify those who are survivors themselves who got infected or their parents got infected in one way or the other. The other would be the children who have been affected by Ebola in terms of missing school, those who are predisposed to early pregnancy and teenage pregnancy during this time that they were left redundant in their homes or villages or communities. The other was psychosocial support and psychological first aid training given to case management workers, village health teams, and all the parasocial workers, basically the government community structures that are in place, such that we can have sustainability of these trainings and of services being offered in the communities, even after the work of Save the Children has actually ended. We have put up play materials for children in community isolation centers, as well as child-friendly spaces in these districts for children who are actually left alone, who are still having parents that are still isolated, to be able to be trained, cognitive development, and also have an area environment of education and studies. Community radios have been put up in all these districts to increase awareness in terms of the South Sudanese Ebola virus disease, how it's spread, prevented, and how to identify or contact tracing among communities, knowing that if one word reaches one, it will spread to so many of them. The other is the biweekly coordination and or case conference for child protection and other health actors in these districts. We have realized, like the earlier presenter, that integration of response is very key. So we wanted to find out if we have actually, during these coordination meetings, that we have actually targeted all the children who have been exposed to issues of child protection or families, and maybe would have left out having lists from other actors that are there, but also trying to refer cases where we need even legal aid or where we need health aid for treatment in terms of any child abuse that has taken place here. Then the other coordination would have been to identify the capacity gaps of the government health workers or other partners in the district who need actually staff capacity building in terms of child protection measures or strategies or plans that can be done during this Ebola response. Thank you so much. I'll hand it over to my colleague, Alex.
Thank you very much. Good morning and good afternoon to everyone. I'm going to share with you our experience on integrating the child protection and health activities during a complex and outbreaks disease in DRC. We are going to talk more on our response on North Kivu and Ituri. As you know, when we talk about DRC, there is many problems like the army conflicts, the insecurity issues, and also this current disease outbreak like this Ebola. As you know, Ebola for the first time it was experienced in DRC. We have these outbreaks of cholera, of measles, and all those bring a complex and long-standing humanitarian crisis in DRC. And this touch very much the children. As you can see, in DRC, we have many children that lost their parent and also a member of their family. It can be directly due to the illness or also for this violence and this army group. We have also some children that are recruited and used by the army group. We have this area, marriage and the 10th pregnancy. We have also this problem of sexual and gender-based violence. And especially for these two provinces that we notice this Ebola outbreaks, there I want to talk about North Kivu and Ituri. Those are the two provinces that are most affected in DRC. You can see, for example, in those two provinces, we have 2.8 million of people who are in needed. So there is also this question and issues about the IDPs. In DRC, you have a big number of IDPs, and as you can see in North Kivu and Ituri, we have a big number of those IDPs. What we can also notice the complexity of these outbreaks. It's for those two provinces, it was the first time to have this Ebola outbreak in the context of the movement of the population. This movement is due to the IDPs. We have also this business between this small village, this small also city, and we have this movement between DRC and the other country. We have also this conflict in this part of DRC that came also with a scale-up of child rights abuse. And as you can see, in North Kivu and Ituri, it represents more than 57.5% of case of violence, violation of right of children. Next slide. What we did during this Ebola outbreak to try to integrate the child protection activities on the health activities. So we start by the activities related to the child safeguarding because we were thinking that this will be also a short-term outbreak for 2 or 3 months. So our accent, it was first to for the training of staff, of partners and volunteers to make sure that the children are going to stay safe as possible. So we try to outline some potential child safeguarding risk on our health program and give a suggestion on how to manage those risks. So we put also another accent on the protection against sexual and exploitation and abuse in this response. There we try to make some briefing to the humanitarian community, and we try to make sure that PCA and child safeguarding mechanisms are within all the health facilities and the community. So related to the children and the EVD, the Ebola virus disease, what we notice is that most of the children was affected directly or indirectly. So we have, for example, in all the case of contamination, we have more than 30% was the children under 15. We have also this parent or a member of the family that were affected by this Ebola. We have also survivors for within the children that also create some discrimination for those children that survive for this Ebola virus, and sometimes there was some marginalization in their community. And also we noticed that there was a high risk, the risk of the contamination was very high within the children. So what kind of action that we put in place? So we try first to increase the mobilization and the awareness, community awareness raising up, and we try to adapt the message. We was working with our health promoters, with the child protection team to see how we can adapt the message and to make sure that children receive the good message, and they will be able to prevent themselves for this Ebola outbreak disease. So the other innovation and that we bring on this outbreak, it was to see how we can also give a support for the children in the Ebola treatment center. So what we put in place, it was first to make sure that we make the training for all the health workers who are working in the Ebola treatment centers, and also the caregiver, because the problem was the children who was isolated in the Ebola treatment center, they were separated for their family, and so that we put in place this kind of activities of caregivers that could support all those children in those isolation area. So we try also to put a good environment for the children that they can just stay safe in those areas. So the other thing that we noticed, it was we have this child protection issues, and the community had other problems. So we try now to come with a wraparound activities that we are going to address the problem, the solution to the problem of the community. So we came with this activities of child protection to strengthen this local child protection network. So we came also with the other activities of primary health care to make sure that the children that are sick can also have access to this treatment of their illness. So also we try to reinforce this health facility that was very weak even if before this outbreak, and to make sure that the children that are there in those communities could stay safe during all these outbreaks. So I think that I'm going to first to stop by there, and maybe ask to my colleague to continue with another presentation. Thank you very much.
Thank you so much to Violet and to Dr. Alex for those very interesting case studies from the field. I'm just going to briefly present or touch on what we're calling the 5 critical actions. These are, you know, we've developed these because practitioners often struggle to identify in practical terms what are the key entry points to ensure that child protection considerations are fully understood and comprehensively addressed as part of preparedness, response, and recovery processes. And based on our research and experience, we propose at least these 5 critical actions. So the first one is related to the development of intake, treatment, and discharge protocols that prevent family separation and promote family unity. The second one is to ensure that health facilities, including those used for isolation, quarantine, and treatment, are child-friendly. The third is to ensure that community-based awareness raising, sometimes called risk communication and community engagement, or RCCE, during outbreaks is child-centered, accounting for the information needs of children and their families. And the fourth is to develop common protocols for safe identification, documentation, referral, and counter-referral of children in need of additional case management. The fifth is to ensure that screening and vaccination rollout is child-friendly in order to boost uptake. So these 5 critical actions must, of course, be contextualized to each type of outbreak and any individual setting, but they provide concrete ways in which protection of children can be centralized in outbreak management. Our next 2 webinars actually focus on the first 3 critical actions, and we have global tools under development for the last 2 critical actions. So let me leave it there just because of time, but let me hand over to Sarah again for the next steps. Thank you.
Great. Thank you, Nidhi, and thank you to Violet and Dr. Alex. So thankfully, we have time now to ask questions and have discussion with our presenters and panelists. So please, if you have a question, share it in the question and answer function, and we'll try our best to answer it. So I think just to start, I'm going to ask Dr. Aisha. So we've heard a lot about interventions here, but I think it would be useful for the audience to know, what does global health law say about children's rights during outbreaks, and why is this important to know in child protection and health integration activities? So over to you.
Thank you, Sarah. And thank you, the panelists, the presenters, for your fantastic presentations. I think the best source of global or sort of international law to look at is actually the Convention on the Rights of the Child. And the reason for this, it's about children's rights, but also it is actually a treaty that has been signed and ratified by a huge proportion. It's been signed by all of the world's countries, and it's been ratified by all except the United States. So it is actually an internationally binding law for almost all of the countries of the world. And it basically lays out a series of rights for children, which we can sort of go through. I think this is not necessarily the place for that, but the key thing to know, looking at if you read the Convention on the Rights of the Child, it goes through a series of rights that children have for things like to not be separated from their family unless absolutely necessary for the safety, the right for access to basically all of the things that they need to be able to survive and thrive, to reach their optimal state of health and well-being. So this is not just healthcare, but it's also about informed healthcare and about being safe in the health care environment and being safe in their communities as well, where they may be receiving care, but they may also be isolated for infection control purposes or whatever. The thing to realize about these laws is that there are a lot of what we would call social determinants of child health that are addressed in them. And I think when we think about social determinants of health and we think about children, there are large groups of the things that there's sort of 3 main ways in which children's health are affected. One is whatever they're born with, their genetic environment and anything, the genetic makeup and anything that's they can inherit. That's actually kind of, it's important and fundamental, but it's probably less important than some of the other things that we can do more about. And that is their social environment. So where they live, what their life is like, what their access to food is like, how often they get it, their safety, whether they can go to school. All of these things have measurable impacts on children's health. And there's lots of evidence that I'm happy to also share with participants about how these different things then impact how that child's body develops, how their brain develops. And then, of course, there's something called epigenetics, where we have a potential for disease, and then something in the environment triggers that gene to sort of wake up, and then the child gets a disease. So when you think about global health law and the Convention on the Rights of the Child, it is the convention addresses not only access to health services and the right to be safe, just generally speaking, but also it addresses all of these social determinants of health. So it's a very strong international legal foundation for why child health and child protection as part of health and safety is critical. I hope this answers your question, Sarah.
Thanks, Dr. Aisha. And I just encourage, I know this is a big topic, so I'd encourage people to continue that conversation in the question and answer, and hopefully Dr. Aisha can respond there. The next question I'd like to ask from the chat, and I'll put this to Dr. Alex, and then perhaps Nidhi can follow up if there's any other points from kind of from a global standpoint. But the Ebola response in DRC really highlighted the gender dimensions of outbreaks. And of course, we need to consider this within child protection. So Dr. Alex, is it possible for you to give us some examples of how these were addressed within child protection? I think you mentioned things like adolescent girls and sexual exploitation risks, removal from school and child marriage, things that already existed in DRC. So can you maybe speak to this a little bit in the context of the Ebola response?
Okay, thank you very much, Sarah, to that question. So as I explained before, we try to identify all the protection issues during this Ebola response. And what we did in collaboration with the other actors, UNICEF and Protection Working Group, we arrived to put some activities in place. We start first to strengthen the child protection community in place. We worked with that we call here DUAS, is one service of the Ministry of Social Affairs. So we strengthen this community and to make sure that they have the good capacity to respond to those questions of child protection abuse in their community. So we start by doing some mapping of all the services that we have in the community, so that we have a good system of referral, so where we can refer all the children with this problem. So we put in place a program of case management, so that we all the children that we identify with the protection issues, we can refer them through this program of case management, and they can also have the solution of their problem. But the other action was also to make sure that we stop the line of propagation of the virus. So most of also our activities, it was in collaboration of our socio-behavior change team and the CP team, to make sure that we organize a good community awareness raising messaging, and to try to adapt the message that we have for the adult to the children. So we have some a session with the children around our health facility that we was supporting, so that we can also make sure that the contamination within the children are most reduced. So the other cause of these protection issues, it was also this conflicts, army conflicts. So there it was very difficult for us to try to find solution for that. But there was also these activities of what we call Recope. Recope is like a network in the community that are working for these child protection issues that we put in place. We try to make some dialogues with them and to see how to involve them to this cause of the children, and to try to improve more and more the situation of the children. We learn more from these Ebola outbreaks, and for that Ebola outbreaks, we develop more strategies for all our disease response, especially, for example, the outbreaks who came after that. It was this COVID-19 response. So we was now more prepared for this integration for the COVID-19 response than to this EVD response. Thank you very much.
Thanks, Dr. Alex. And Nydia, is there anything around gender within child protection that you think it's important for the audience to take away from this webinar?
I mean, in 1 or 2 minutes, I would say the key takeaways would be to consider the intersection between age, gender, and disability when looking at programming options or looking at the needs of the population. So to really understand that children are not a homogeneous group. There's so much variation from age, from infant to adolescent, but also that the intersection between the age and gender makes such a difference. So for example, in DRC, where we see girls of an adolescent age or even pre-adolescent age, maybe because of social cultural reasons, more likely to adopt the roles of caregiver within the family, or which might be caring for the sick, possibly exposing themselves also, because they're, in the case of Ebola, might be in contact with bodily fluids. Caring for the dead is also a role ascribed typically to females within DRC, within Congolese culture. There's also the increased water needs, water and sanitation needs within a household as part of the Ebola response, and that will often fall to adolescent girls. So I think the key takeaway is just in analyzing any particular context is to understand what are the key intersections between age, gender, and if I had more time, I would also talk about disability. But that's kind of the key message I hope that attendees can at least take away from this. Yeah, thank you.
Thank you, Nydia, much appreciated. Next question I'd like to ask to Jean. We touched on some of the kind of global minimum standards. And I think, speaking as a health practitioner, we always talk about protection mainstreaming. I wonder if you could explain a little bit more about what the difference is between child protection and health integration and protection mainstreaming, or what are the similarities and where do these two terms fit together? I think maybe Jean is having some connection problems, so we'll come back to that question. Next, I'd like to maybe stick on the side.
Sarah, you've gone on mute.
Sorry, we're muted.
Apologies. So I think Jean is frozen. So we're just, I think I'll just direct the next question and hopefully we can come back to Jean when she comes back. Violet, thank you so much for your presentation. I think it's really interesting to hear this from the point of view of a health team member. And I think in the beginning of major outbreaks, it can often be very hectic for health teams. And a lot of the time they're preoccupied with setting up treatment centres or emergency response teams, infection prevention control measures, which you mentioned. I wonder what you think can be done to ensure child protection is integrated from the very beginning, even in preparedness phases, and if there's any examples from Uganda.
I think the first thing I would say is that even in the establishment of the Ebola treatment unit, we should be considering the safe space for children alone, or mother-baby areas, or what we can say IYCF areas for the breastfeeding mothers, because we had cases where mothers were coming in where their children were infected and she still had to breastfeed this child. So I answered that in one of the questions, that how were they allowed to breastfeed? Yes, we were actually encouraging the breastfeeding, but making sure that the mother follows all the SOPs that were supposed to be done during the ETU, less exposure of the adults, but only separating the mother with the baby who is actually being breastfed at that particular time. So this is how we manage that, but that is one of the key things or examples that we can see where integration of child protection needs to be done immediately. The other would be that as we are doing contact tracing or training the VHTs in doing the contact tracing and health education. It's the same time that we should actually be thinking of structures like parasocials or volunteers who will be going out to actually identify cases of children who are already maybe left alone, abandoned because of the identified cases of Ebola for their caregivers, and for mental, psychosocial help and counseling, and maybe keeping them busy such that because they are out of school, they should have children safe spaces in the communities where they can be engaged in terms of educating them, making them be the champions in actually advocating for good hygiene and sanitation practices, practices that can spread Ebola to their fellow children using child-friendly IEC materials. So this is something also that we identified, and so that was very good to start from the beginning. As you're training the VHTs, you're also training the other social workers who are going to deal with the people, the children who are left in these communities alone, abandoned, and mostly tackling those that are out of school due to the Ebola outbreak, and making them busy and occupied and giving them the education on how to prevent this disease.
Thank you, Violet. Some really good examples there. And I guess still sticking on the kind of readiness aspects of this, and I'll first ask this to Dr. Alex. Obviously, DRC have been dealing with Ebola for 2 years now, or more possibly. And lots of outbreaks of other diseases as well, cholera, measles, etc. And then obviously compounded by COVID-19. So I'm wondering what lessons you have learned from the child protection and health integration in Ebola that you have brought forward into managing other disease outbreaks such as COVID, measles, cholera. So yeah, over to you.
Okay, thank you for that question. So the first lesson that we learned from this Ebola outbreak disease, it was that we have to integrate the child protection activities in our response preparational plan. So when we have to prepare the plan for how to respond for the outbreak, we have also to start to integrate the CP activity there. So when we are doing this preparation, we have also, for example, to start to do also the child safeguarding analysis in our catchment area. So we have to collect also all the information related to the child abuse, so that we can also well prepared to integrate these CP activities on our response. So we need to know the really problem of the children in our catchment area, and to try now to start now to integrate all those CP activities from the beginning of the response. So, for example, in our plan for now, we try now to put a link between the health facilities and also the children. For example, what we try to put in place is the plan of training of the health workers, for example, to identify the children with problem when they come to their health facilities, and that they can also be able to provide the first psychological, for example, first aid support for these children, and also to put immediately in place a referral plan, so that the children with a bigger problem, we can just also refer them immediately. And also for the health side, we also want them to involve more what we call the community health workers that are working in the community for the awareness of their child protection messages, and also to know how to identify children with a problem, and to know also how we can refer them for a good support. And in all our plan, we try now to highlight and to make sure that we have a budget not only for the child safeguarding activities, but also to put in place also the budget for child protection activities within the health, our health program. And I can say, I said before, this, for example, Ebola outbreak disease of North Kivu help us a lot to be prepared very well to also respond to COVID-19 response. So for this COVID-19 response, it was like now we are very equipped. We have now a big knowledge, and it was easy for us to respond now to that outbreak. And this is known for all the outbreaks, because we have this outbreak for cholera, for measles, and we try now to integrate everything, and we make sure that before starting everything, all the health workers and all the humanitarian community must be also briefed and trained on child safeguarding also topics. Thank you.
Thanks, Dr. Alex. And welcome back, Jean. I'm sorry for your connection issues. Can you hear us now? She's gone again, has she? Okay. Oh, Jean, you're back. Okay. Can you hear us?
Yes, I can, Sarah.
Great. So I'd really like to ask this one to you. So I think there's a common theme coming up within some of the questions.
Yes, I can. Can you hear me? Yes.
Yes, we can. Okay, I think there might be a bit of a delay, but we'll try. There's a common theme coming up.
Yes, I can.
Okay, there's a common theme coming up in the chat around custom beliefs, traditional beliefs, and how child protection and health actors can address these. And also, I suppose this is linked to what community networks we can engage with. So I just wondered if you could give us a couple of minutes on that. Okay, Jean, sorry, we can't hear you. I think I'll hand that over to Violet. Violet, do you mind answering that? I know you answered one in the chat. So. Oh, you're on mute.
Sarah, could you please answer that again? We didn't get it.
Yeah, absolutely. So I think there's a common theme coming within the chat about trying to overcome these very strong customs and traditional beliefs that are held within communities, especially during outbreaks.
Yes.
And also just around what networks can us as child protection and health actors engage with to be able to, you know, I guess, try to change some thinking around these beliefs. So yeah, over to you for the last question.
Okay. So for Save the Children here in Uganda, we identify the key influencers, both in the religion, culture, traditional setting. Who do the communities listen to in terms of the key influencers in these three kind of major areas? So while we are doing the community mobilization, the community education and sensitization, these are the key influencers that we are first trained and so that they have a buy-in to child protection during this Ebola response and understand why we actually are advocating for certain practices to be changed or certain measures to be taken in relation to child protection, safeguarding, and all these issues. Once they have the buy-in, they become kind of like TOTs. And while we are going in for the community dialogues, for the community drives, for the radio talk shows, these are the people that we are actually going in and moving in with. Especially, for example, in Uganda, we had an issue where majority of the cases that were identified of families that had a suspect were rushing to the traditional witch doctors other than going to the facilities. And they preferred going to the witch doctors thinking that maybe this is a traditional kind of issue, or they will not have a lot of spending money. But when we had these traditional doctors having in binds and teaching them that this is a disease that needs to actually be treated in hospital, the treatment is free, this is how it is spread, and this is actually the severity of this disease, and the consequence is actually death within these specific hours, then this is how we started having a change where people had contact tracing themselves and then also referring these cases and they themselves being self-referral to their health facility. So the buy-ins of the key influencers in the traditional setting, the culture setting, is actually very key, and inclusive, having meaningful participation in health education, child protection, sensitization, together with these key influencers or traditional people or cultural leaders, is actually very key in helping to stop the disease.
Thanks so much, Violet. Thanks for asking that last question. So I'm afraid, everyone, we're at time, and that went very, very quickly, that hour. So Virginia, if you just bring up the closing slides, please. So the last thing just to say is that we will send you some extra reading by email, but we'd also like to direct you to the Ready resource library, which has abundance of multi-sectoral tools that you can search and guidance that you can search for by topic, disease, resource type, and in different languages. We also have the Ready Learning Hub, which has over 60 courses curated from Ready, WHO, UNICEF and more, and also some outbreak simulations to play. And of course, all these courses are available free. So thank you very much, everyone. Thanks so much for your time, for your questions. Thanks to the panelists and presenters. Thanks to the interpreters, who I think were working very hard behind the scene. Special thanks to BHA and also our regional colleagues in East and Southern Africa for their guidance. And of course, thanks again to the audience. We hope you'll join us for the next webinar, which is on the 1st of February at the same time. So it's 15:30 to 16:30 East Africa time. Register now if you haven't already. And the following one on the February 15th, which will be about communicating with children in infectious disease outbreaks. Links will all be in the chat. Thanks, everyone. Sorry for being 2 minutes late. Good morning, good afternoon, good evening, and thanks again, and hope to see you next time.